I'm going to turn the slides over to Dr. Acharya, who is the Director of Hemostasis and Thrombosis at Northwell Health here on Long Island. Dr. Acharya, thank you.
And good morning, everyone. Happy Saturday. Hope and thank you for joining this webinar. Hope everyone is staying safe and healthy. I'm going to attempt to share my screen. It's a pleasure this morning to be discussing congenital fibrinogen deficiencies with my co-presenters, Dr. Marilyn Manco Johnson, who's a world-renowned expert in this field, and Dr. Alyssa Wahlberg. And I want to thank HANY for this opportunity. So as Linda has mentioned, I am Suchitra Acharya from the Cohen Children's Medical Center at Northwell Health. So what we are going to do, Marilyn and I have distributed this talk, the clinical aspects of it. I'm going to be discussing some mildly symptomatic patients, and Marilyn is going to share her experience with the more severe symptoms with this particular disorder. So in the next, hopefully, 20 to 30 minutes, I'm going to touch upon the role of fibrinogen in the clotting cascade, some definitions, laboratory diagnosis, which Marilyn will discuss in depth, as well as treatment options. I always like to share this visual cartoon, which I've had permission to share from Drs. Usha Reddy and Roshni Kulkarni, who developed this. It really, from my perspective, is a great visual to see how clotting occurs in the body. I just wanted to mention that fibrinogen, of course, plays a major role in the final steps of the clotting process, where you generate thrombin as a result of activation of proteins involved in the extrinsic and intrinsic pathway. And fibrinogen converts, thrombin activates fibrinogen to fibrin. And then there's factor 13, which cross-links the fibrin in order to form a tensile clot. And finally, the vessel, returns to normal. Okay. So fibrinogen is synthesized in the liver and has a multitude of functions. After fibrin clot formation, exposure of some of the binding sites promotes the antithrombotic properties of fibrinogen. And this basically accounts for some of the symptoms that we see when the fibrinogen molecule is modified, either quantitatively or qualitatively. So you can have bleeding symptoms, and paradoxically, you can have clotting symptoms, forming blood clots in arteries and veins. The normal fibrinogen concentration ranges from 150 to 350 milligrams per deciliter, but this is also dependent on the lab and the type of assay. And so each laboratory has their own standards. It roughly has a half-life of about 4 days, and typically levels more than 100 milligrams per deciliter can prevent excessive bleeding. So this slide basically highlights the fibrinogen molecule. Fibrinogen is a product of 3 genes, which are on chromosome 1, the gamma gene, the beta gene, and the alpha gene. And these encode polypeptides, the alpha, beta, and gamma chains. So you have the E domain here, where all the 3 chains meet, and the D domain, where the beta and gamma chains meet. And you need to have proteolytic cleavage of these chains and differential polymerization in order to account for the various symptoms. And some of this is still under investigation. As these chains break down, there are abnormal fibrin products, either because of the quantitative or qualitative defects. And these abnormal fibrin products can cause defective cross-linking by factor 13. And in this manner, you have delayed healing also as a manifestation of individuals with these fibrinogen disorders. These congenital fibrinogen deficiencies are classified into quantitative as well as qualitative defects. The quantitative ones are afibrinogenemia, where very minimal amounts of fibrinogen is produced. In hypofibrinogenemia, some amount of fibrinogen is produced, but it may have reduced activity. Dysfibrinogenemia, typically the amount of protein produced is normal, but it has reduced activity. And a lot of times individuals with dysfibrinogenemia, about half of them may be asymptomatic, whereas a smaller percentage can bleed, as well as another small percentage can clot. So as you can see, it's a whole spectrum of symptoms in these disorders, which makes this still very intriguing and very interesting. So an individual who presents with severe bleeding symptoms, typically we do a bleeding screen, including the complete blood count in order to assess the platelets, as well as the PT or prothrombin time and the APTT or activated partial thromboplastin time to screen for the various clotting proteins. A fibrinogen level ascent, which is a fibrinogen activity, and the thrombin time, which is basically determines the quality of the fibrinogen and also the rate of conversion of fibrinogen to fibrin. If the PT and PTT are prolonged and the fibrinogen activity is low, this is confirmed by sending fibrinogen activity by the Klaus method, which is a much more accurate method to estimate the fibrinogen level, and a fibrinogen antigen, which estimates the quantity of the protein, is also assessed. When you ultimately determine what the diagnosis is, whether it's afibrinogenemia, hypo, or dysfibrinogenemia, it's really important to send for molecular testing to determine the genetic mutation, because this may have implications in terms of the bleeding, the clotting symptoms, or if you are going to be asymptomatic. And that's still under investigation. I don't think we still have a great handle on this aspect of it and requires much further work. If there's availability of a new set of tests called viscoelastic testing, such as the thromboelastography or rotational thromboelastometry, it may be possible to use this to monitor clot strength, specifically when these patients are treated with fibrinogen concentrates. It really helps to monitor the strength of the clot and also how frequently to dose based on this testing. These tests essentially tell you the time taken to initiate the clot, propagate the clot, and also the strength of the clot. If a low fibrinogen is detected when a patient is acutely ill, it's extremely important to rule out disseminated intravascular coagulation, which typically occurs in the setting of a serious infection and other liver and kidney disease. This slide summarizes the clinical and laboratory characteristics of individuals with afibrinogenemia, hypo, and dysfibrinogenemia. Since afibrinogenemia is the most severe of these disorders, they may be diagnosed early in the newborn period. Hypofibrinogenemia typically is diagnosed post-trauma or after a surgical procedure, whenever that happens, either in a child or an adult. And dysfibrinogenemia is usually diagnosed in adulthood. Most afibrinogenemia patients will be symptomatic with bleeding symptoms, which is more common, and some of them also have clotting symptoms. Some of the hypofibrinogenemia patients may also be symptomatic. Dysfibrinogenemia patients tend to be symptomatic and present with clotting symptoms, and this is also dependent on the type of mutation that is inherited. Afibrinogenemia is autosomal recessive in inheritance, which means both parents need to be carriers in order for the child to inherit this disorder. Hypofibrinogenemia and dysfibrinogenemia are autosomal dominant, where usually one parent has a mutation and there's a 50% chance of transmitting this to the progeny. The screening tests, PT and APTT, and the thrombin and reptilase times are infinitely prolonged in an individual with afibrinogenemia. With hypofibrinogenemia, it depends upon the level of the fibrinogen, and the PT and PTT may be mildly prolonged or even maybe normal. And the thrombin and reptilase times are usually prolonged when the fibrinogen levels are less than 100. In dysfibrinogenemia, both the PT and PTT tend to be normal, but the thrombin and reptilase times tend to be prolonged because this is a qualitative defect, and thrombin and reptilase times assess the qualitative defect. When you do the antigen and activity in somebody with afibrinogenemia, it's typically undetectable. In hypofibrinogenemia, there's a proportional decrease in the antigen and activity, but in a given family, the levels tend to be highly variable, and so does the clinical severity. In this fibrinogenemia, which is the qualitative defect, the antigen is normal, whereas the activity is decreased. And again, this depends on the type of inherited mutation. And of course, genetic testing is indicated in all these different subtypes of these fibrinogen disorders. In 2020, the treatment of choice for somebody with afibrinogenemia or hypofibrinogenemia is a single factor plasma-derived concentrate. If that is not available for any reason, the second choice is cryoprecipitate, and fresh frozen plasma or FFP should be the last choice. There are two fibrinogen concentrates that are approved, Riastap and Fibriga, and a third concentrate is actually has completed clinical trials and submitted to the FDA for approval. Since skin and mucous membrane type of bleeding is very common in these fibrinogen disorders, and there's an abundance of clot breakdown enzymes or fibrinolytic enzymes in these areas, antifibrinolytics or clot strengthening agents such as tranexamic acid and aminocaproic acid form a major component of the therapeutic armamentarium of these disorders. Depending upon the degree of anemia, red cell transfusions and iron supplements may be required in these individuals. So now I'm going to switch to describing a couple of patients in whose care I've been involved. So we were referred a 17-year-old male prior to wisdom teeth extractions because he was told he has a rare bleeding disorder. He and parents also reported that he's had a lifelong history of easy bruising. Usually bruises range in size from dime size to quarter size bruises, specifically if he's, roughhousing with his brother. He also reported gum bleeding with brushing his teeth, but he's never really had any significant anemia for which he's required iron or red cell transfusions. Parents reported that he's physically active, he plays tennis and he swims. The interesting thing when asking about the past medical history, they reported that when he was 3 years old, he actually fell when he was walking on the pavement and developed a very large hematoma, they described. They said it was almost like a head attached to a head. And that's when they were back home in Iran, and he was investigated further for this and treated with cryoprecipitate. He's never had any other previous procedures. Both parents, first cousins from Iran. Mother reported a history of heavy menses, postpartum bleeding after her 2 children. His younger brother and father reported no significant bleeding symptoms. So we obviously sent out some laboratory testing on him, and I'll show you a slide with the details of this. So his blood counts were normal, his CBC was normal, but his PT and APTT were extremely prolonged, and this was repeated, twice in order to make sure that these results are accurate, and then his fibrinogen levels were undetectable. So this slide basically highlights what I just described: normal hemoglobin and platelets, and infinitely prolonged PT, PTT, thrombin, and reptilase times, undetectable fibrinogen activity and antigen. And this, we also could send genetic testing, and he has a mutation in the FGG gene for which he is homozygous, and this confirms his diagnosis of afibrinogenemia. So the plan that was made for this upcoming dental procedure was to obtain his fibrinogen activity pre-procedure along with a blood count to see where his baseline is, and then he got an infusion of a fibrinogen concentrate followed by tranexamic acid, the clot strengthener, and we repeated his PT, PTT, and fibrinogen after his infusion, and both these numbers had completely normalized. He did not have any bleeding at the procedure or post-op, and subsequently he's really been bleed-free. So this patient's history and laboratory findings highlight afibrinogenemia, where he is essentially mildly symptomatic only with trauma or procedures. So whenever there's a history of trauma-related bleeding, I think it's really important to keep in mind that if they do undergo a procedure, they will need replacement, because there's a high likelihood that these individuals will bleed at procedures. Going to the next patient, a 15-year-old female was transferred to our emergency room from an outside ED for history of dizziness and headaches. She reported history of prolonged menses, and this was now the 10th day that she was bleeding. She started menarche at age 10. Her cycles typically last 10 days, and she claims she changes, every couple of hours for the first 3 days. And off and on, she's been anemic and is prescribed iron by her primary care physician, but not very compliant with the iron. According to the father, she was also diagnosed with a rare bleeding disorder back home in Mexico. And at the age of 10 months, when she was just learning to walk, she tripped and fell and hit her head and had a huge swelling in her right eye. Subsequently, they attempted to do some kind of a procedure, but it just made the swelling worse. And she lost vision in that eye. And currently, she's like legally blind in that one eye. A similar history was reported in her 30-year-old sister with history of easy bruising, heavy menses. And the sister, there was also a report of right ankle swelling, for which took almost a month to recover. Both parents from Mexico, they're first cousins, and there was no significant bleeding history in either parent. So these are her laboratory values. As you can see, she has a low hemoglobin, her platelets are normal, and her PT-PTT, thrombin and reptilase times are extremely prolonged, and her fibrinogen activity and antigen are extremely low, undetectable. So she also has a diagnosis of Afibrinogenemia. So the plan for her heavy menstrual bleeding was twofold. In the short term, because she needed a red cell transfusion, she was symptomatic, she got IV iron, she also got a fibrinogen concentrate along with tranexamic acid, and she was counseled on consuming an iron-fortified diet. The other thing that I recommended to her is to keep track of her menses, because we needed to figure out what the ultimate long-term plan for her menstrual bleeding was going to be. And this is the Sisterhood app, which is the electronic version of the pictorial bleeding assessment chart, which a lot of you may be familiar with, where you can record objectively the amount you bleed, whether it's mild bleeding on a pad or tampon, moderate bleeding, or pad or tampon that's completely saturated. And this is important when any kind of treatment regimen is instituted to see the efficacy of the particular regimen. And so for long-term purposes, I counseled her about getting a levonorgestrel IUD, also known as the Mirena IUD, which is really effective in girls and women with heavy menstrual bleeding, even in the general population. And we found it to be effective even in girls and women with bleeding disorders. Advantages of the IUD is you avoid the systemic side effects that you typically have with birth control pills, such as mood swings and weight gain, and it stays in for at least 5 years, and you don't have to be reminded to take a pill every single day if you are on oral birth control pills. And after that, and since the Mirena IUD, her bleeding has really completely resolved. She's really doing extremely well. We're awaiting doing genetic testing on her to figure out what her mutation is, because this would be important for her future in planning future treatment regimens in case she needs something down the road. Rare bleeding disorders, and this is basically a list that I've shown in this pie chart, comprise 3 to 5% of inherited bleeding disorders. And amongst the rare bleeding disorders, the prevalence of factor 1 or fibrinogen deficiencies is about 8%. And this is data that's been published from the World Federation of Hemophilia survey, as well as the European Network of Rare Bleeding Disorders. Our understanding and knowledge about rare bleeding disorders has really advanced because of some registries that were maintained in the UK, Italy, and Iran. And if you look at the data from these registries, the prevalence of factor 8 and factor 9 deficiencies, which are hemophilia A and B, seem to be similar in these 3 registries. But when you look at the rare bleeding disorders, and I've highlighted fibrinogen, you will see that it's 3 to 5-fold higher prevalence in the Iranian registry as compared to the registries from Italy and the UK. And why is this? There's a very high rate of consanguinity in countries in the Middle East, as well as Southeast Asia, anywhere ranging from 40 to 85%. And this translates into a 3 to 7-fold higher prevalence of rare bleeding disorders in the Middle East and Southeast Asia as compared to the Western world. So it's always important when investigating a patient for a rare bleeding disorder to ask for a history of consanguinity, because that would help a lot of times in a better understanding. Some of the clinical manifestations, a lot of these fibrinogen deficient individuals could be asymptomatic. Some of them can have mild bleeding symptoms, severe bleeding symptoms, and some of them can have clotting symptoms. But the most common symptoms are bleeding into the skin and lining areas. And also persistent umbilical cord bleeding should be a red flag, because this could be a presentation both with fibrinogen deficiencies as well as factor 13 deficiency. Individuals with fibrinogen deficiencies also have a tendency to develop spontaneous bleeding into the brain, while joint and muscle bleeds tend to be rare. There's delayed wound healing, especially after surgical procedures, and this really needs to be kept in mind when planning for a surgical procedure and making sure replacement therapy is given until the healing is completed. And sometimes these patients can present with cysts in the spleen and in bones. Girls and women can present with heavy menses, as seen in our second patient, and first trimester abortions are common in the absence of fibrinogen replacement. So apart from this, we've known a lot about and learned a lot about fibrinogen deficiencies and rare bleeding disorders over the years through collaborations through the World Federation of Hemophilia and the European Network, as well as the American Thrombosis and Hemostasis Network. But there is still no clear understanding if there is a genotype-phenotype correlation, which means that are there certain mutations that actually will predict whether you will bleed, you'll clot, or you will be completely asymptomatic, especially in the afibrinogenemias and hypofibrinogenemias. With the dysfibrinogenemias, I think we do understand there are certain mutations that correlate with a tendency to develop blood clots. So ATHEN-10, which is the American Thrombosis Hemostasis Network study through the American Thrombosis Hemostasis Network, is actually offering genetic testing for afibrinogenemias in the first round. And if any of you in the audience are part of a hemophilia treatment center, I think it's important to avail of this testing. I think there's also a need for more commercially available standardized laboratory testing to improve diagnostic accuracy. When using a fibrinogen concentrate, currently it's unclear how to balance the risk of bleeding with the risk of clotting, because there is some data that there may be an increased clotting risk with the use of fibrinogen concentrates. Also, the role of fibrinogen concentrates in the dysfibrinogenemia disorders who have a tendency to develop clots is still unclear. And I think it's also important to identify risk factors to prevent thrombosis in the quantitative afibrinogenemia and hypofibrinogenemia patients, who also tend to have a risk of developing clots, which Dr. Manco Johnson will further elaborate. In 2020, individuals with rare disorders such as afibrinogenemia should be cared for by a dedicated team, and these individuals are part of a hemophilia treatment center. And these HTCs were established in the early 1980s through the Maternal Child Health Bureau and the CDC. And there are about 130 centers of excellence nationally. And these HTCs are comprehensive care models for specialized preventative care. And for hemophilia, we have data that mortality was definitely decreased when a patient with hemophilia got care at a comprehensive treatment center. These treatment centers are a multidisciplinary team of hematologists, adult pediatrics, nurses, nurse practitioners, and genetic counselors, other subspecialists, And these HTCs serve as a medical home, providing diagnostic and treatment plans, and are typically focused on preventing bleeds, preventing complications that surround the bleeding disorder diagnosis, as well as focused on education. HTCs collaborate with the primary care physicians as well as subspecialists, schools, and daycare centers. And since they do conduct all these multitude of functions, they also monitor outcomes of the care that's received through data collection and in the forefront for identifying emerging problems. Thank you for your attention, and I will now turn this over to Dr. Marilyn Manco Johnson for her presentation. Thank you.
Maybe you have to stop sharing screen.
Yeah.
Now, oops,
Thank you, Dr. Acharya.
Let me see. Okay, good morning. As you heard, my name is Marilyn Manco Johnson. I'm a pediatric hematologist at the University of Colorado it's actually Aurora, Colorado, outside of Denver. And our Hemophilia and Thrombosis Center treats both adults and children with bleeding disorders. And I'll try not to repeat anything that Dr. Acharya already discussed. I think that was an excellent presentation, so thank you. And hopefully we'll have lots of time for questions. Okay. So just a little bit of the background, and I'm sure Dr. Wahlberg will give us a better one. Fibrinogen is a very special and unique protein. So it's produced in hepatocytes, which are the liver cells. And so what you have is a dimer, which means a linkage of two partial proteins, and each partial protein is made up of three distinct peptides. So there's an A alpha, a B beta, and a gamma. So two of these, so you have two A alphas, two B betas, and two gammas. So it's actually 6 different peptides, mirror image of two triplets. So the molecule, as you could imagine, is very large, and Dr. Acharya showed the E domain where all the chains meet, and the D domain where the B beta and gamma meet. So she talked about the role of thrombin, but thrombin cleaves off these small peptides, and that allows the protein to polymerize, and it actually elongates by associating end to end and also side to side. And the side to side is syncopated. So the little purple dot, which is the it cross-links with these. And so they D to D links in a linear fashion, and D to E is a cross linkage. And this makes what I visualize as a fishnet, which gives it a lot of integrity. And fibrinogen is a stretchy protein, so it contracts down like a bag. And so when you have a blood clot, when you have an injury and you bleed, there are red cells in the clot and platelets and the fibrin clot, and this fibrinogen contracts and squeezes down and pulls everything into a tight knot so that it doesn't block the circulation through that blood vessel. It's the 3 genes are very interesting because they're all encoded on the same chromosome, chromosome 1, and they're in line with each other. And interestingly, although there are 3 distinct genes, they're regulated in a very coordinated fashion. So all 3 are turned on together and turned off together, so that in the normal state, you have equal amounts of all of the chains. So fibrinogen is the actual physical clot. So we've all gotten abrasion on our knee or elbow, and when we see that there is a little bit of blood and we lose some of the skin in the abrasion, we see this little yellow sticky fluid come out. And this sticky fluid is actually the fibrinogen in the fluid part of blood that is forming the clot to help prevent bleeding at that surface. And as you heard, it does promote platelets binding here, and also the retraction or the squeezing down of the clot. But a very important thing I want to emphasize is that fibrinogen inhibits the pro-clotting action of thrombin. I want to show that. Deficiencies and dysfunctions cause one of the most common rare bleeding and clotting disorders. So afibrinogenemia itself is very uncommon, but if you take all the A, hypo, and disc, there are quite a few variations of fibrinogen. So this slide shows the clotting pathway, and we have actually two pathways that end up with thrombin, the important enzyme. And these pathways are not separate, but they're interlinked. So this important protein, tissue factor, is outside of blood vessels. It's in the tissue, and when you have an injury like a scrape or you get a trauma to a muscle, then tissue factor becomes exposed to the blood, and with a blood factor called 7, it starts to activate the clotting factor. So it activates 9 to 9A. And then within the blood vessel surfaces, there's another system called the intrinsic or contact system. And by irritation with cold, heat, trauma, the factor 12 activates 11, which then goes on to activate 9. So hemophilia with either a deficiency of factor 8 or factor 9 is such an important bleeding disorder because both pathways can converge here on the activation of factor 10, which requires both 8 and activated 9. So the two, and so this is like a cascade. And so if one molecule of 12 activates 50 11s and 111 activates 59s, you can see that we're like rapidly increasing and exploding the number of activated enzymes that we have. So activated 10 in a complex with factor 5 and prothrombin activates prothrombin to thrombin. So Dr. Acharya showed that that thrombin actually cleaves those little peptides from the fibrinogen to make the linear clot. It then activates factor 13 to cross-link that clot and make it a fishnet. It activates another protein called TAFI, which is a thrombin activatable fibrinolytic inhibitor. So fibrinolysis is the dissolving of the clot. And so thrombin activates a carboxypeptidase enzyme, which makes the clot more resistant to breaking down. Okay, so the enzyme plasma that breaks it down is slowed down. So thrombin, on the one hand, promotes clotting because it activates these scaffolds 5 and 8. So you have a little bit of tissue factor 7A all the time, activating just a little bit of clotting in the circulation. And when you have a trauma and you really need a clot, a little bit of thrombin is activated, and by activating 5 and 8, it increases this system 1,000-fold. And at the same time, thrombin activates a lot of processes that makes the clot not only form, but be tight and to be resistant to breaking down. Now, the body has a number of systems to regulate clotting so it does not become excessive and does not cause a pathologic blood clot. So since the tissue protein, tissue factor, initiates a lot of clotting, there is a unique protein called the tissue factor pathway inhibitor, which binds to factor 10, and the two of them will inactivate tissue factor 7. So that prevents tissue factor from getting out of hand and causing clotting in the bloodstream where we don't need it and extending the clot too far. Antithrombin is a very, very important protein. This protein is made in the liver, and there's never been a human being born without any antithrombin. So it's so essential to life that it would cause death at the stage where we're just an embryo. And antithrombin inhibits a number of the enzymes like activated 11 and 9 and 10 and thrombin. And so antithrombin is very important, and families who have a genetic deficiency of antithrombin develop excessive blood clots. It can be at birth, but typically starts at or shortly after teenage years. And then the very important accelerators of clotting are factor 5 and factor 8. These are not actually enzymes, but proteins that, when activated, form as physical scaffolds and hold up the proteins that need to activate clotting enzymes. And this regulator of this is the protein C system. So there are a whole number of proteins, protein C, thrombomodulin, the endothelial protein C receptor. So these are, we typically think of the tissue factor pathway inhibitor antithrombin and protein C as the main regulators. And we often lose sight of the fact that fibrinogen is a really important regulator of clotting, because thrombin binds to fibrin and fibrinogen. And when thrombin is bound to fibrin, it inhibits the procoagulant effect of fibrin to activate factors 5 and 8. Thrombin also activates platelets, it activates cells, but it doesn't destroy the thrombin. It just holds it, and the thrombin can be later released. And in a certain condition called antiphospholipid antibodies, there is a very proclotting antibody that causes the body to form large clots, and those clots are holding a lot of thrombin inside. And when you use special drugs to dissolve those clots, when the fibrin is dissolved, the thrombin that was held to them is let go and released. And I actually have been in the radiology intervention suite where a young boy, a teenager with a huge pulmonary embolus, had a catheter put into his clot, and we were infusing a protein called TPA to dissolve the clot. And under dye and X-ray, we could see on the screen that at the end of the catheter where the TPA was going in, the clot was dissolving. And at the far end of the clot downstream, it was growing because the thrombin was coming out of the back of the clot and forming a new clot in the front. So that shows us just how important fibrinogen is to hold on to thrombin, and what a deficit it is if we don't have any fibrinogen to hold on to it. Dr. Acharya talked about some of the global assays. So global assays are assays that try to look at the whole gestalt of clotting and not just the individual proteins. And actually, Dr. Wahlberg is an international expert in this. So when we talk about flowing blood, it's called blood rheology. So this is a thromboelastogram, and this dark black is a normal curve. So when you start to clot, there's a little lag time that's usually anywhere from 5 to 10 minutes. And then there's an enzymatic phase when you're generating those clotting enzymes very rapidly, and the clot starts to form. And then this is the maximal amplitude of the clot. The bluntness of this curve is how fast it's forming, and this is the lag time. So this is a person with afibrinogenemia who did not have a complete absence of fibrinogen, right, from a prior treatment, still had a little bit, and received cryoprecipitate. Cryoprecipitate is a fraction of the plasma of blood, and a young fellow named Judith Graham Poole was in Seattle training in blood banking, and she realized she was trying to make frozen plasma that when she thawed it, certain large, heavy proteins precipitated, and they include a factor VIII, fibrinogen, von Willebrand's protein, and factor 13. And this precipitation had a small volume, so you could give those proteins in high concentration in a small volume. So before we had fibrinogen concentrates, that's what we used to use to replace fibrinogen. And this is a person who got cryo. So you can see that because the thrombin generation is normal when you have no fibrinogen, because that's all before the fibrinogen, the lag time is normal. But you can see that this lag time is a little longer, that the rate of forming a clot is the enzyme development is very slow. So this is very blunt and this is very acute. So you see this wiggly, pathetic little clot. And after cryo, it gets quite a bit better. But you can see, and here is the same individual before getting fibrinogen concentrate. And you can see with the fibrinogen concentrate, you get a much better angle. You get a brisker clot formation, and it looks more like the normal curve, and you have a bigger maximal amplitude. So there are many, many advantages of fibrinogen concentrate over cryo. You get a better clot. It's smaller volume. And very importantly, cryoprecipitate has other plasma proteins in it. And for example, if a person ate strawberries, there could be some strawberry antigens. And if you receive this cryoprecipitate from plasma over and over and over again, you almost always become allergic to some of the non-fibrinogen proteins that are in that cryo, and they give pretty severe allergic reactions when you get infusions. Well, this is another way of looking at blood clotting, and this is called a clot formation and lysis assay. This was developed in Colorado by one of our fellows, Dr. Neil Goldenberg. And this shows a normal adult has a little lag time. And this is plasma. Plasma is clotting in a spectrophotometer with light going through it. So as the plasma clots, the light transmission changes. You see a steep upslope of the curve. And then when you have a maximal curve, the change in absorbance goes down. So this is a normal curve. And here's a person with no fibrinogen. They're completely on the bottom because they don't have any turbidity or cloudiness of the plasma because they have no fibrinogen. After receiving fibrinogen concentrate, you can, and this is like 3 different studies, you can see that that you, in these cases, didn't form a normal clot, but you were much better. And I want to point out that when you form a clot with afibrinogenemia with replacement, your clot formation is pretty much right under the normal curve. It's not delayed. It's not usually that much faster. It's at the normal place, but smaller. This is another test that actually measures the enzymes that are generated. Thrombin is the clotting enzyme, and plasmin is the dissolving enzyme. And this is a person with a fibrinogen less than 5 milligrams per deciliter, so very low. And here is the black is the normal thrombin generation. And this is very subtle, but the gray line is a person with afibrinogenemia. So they have no fibrin, but they can make thrombin. It's generated a teeny bit earlier. So it's a little bit to the left, a little bit earlier than normal, and it follows the normal curve. But the clot dissolving enzyme plasmin is shown here in black in the normal control. And the person with no afibrinogenemia, there is no plasmin generated. So in these cases, you generated enzyme, and then it cleaves a substrate that makes a fluoroscopic change that you can measure. So you need the fibrin clot scaffold to form plasmin. So you can see that a double deficit of no fibrinogen is you're making normal thrombin, but you cannot make any fibrinolysis. And this may be why it seems that people may be hypercoagulable with afibrinogenemia after they get treatment, because they've not yet, for a transient period, they've not yet developed their fibrinolysis. And then this is after getting fibrinogen concentrate. So what's interesting is that the time to formation of the clot in the gray, the person with afibrinogenemia, look, it's shifted way to the right. So this is a child, and children have a longer lag time in forming a clot. This is where the fibrinogen is less than 5, and here it's 152. So they get a near normal peak of clot, but it's delayed, which is healthy in a child. And the plasmin is a little bit delayed, but it's now much closer to the normal curve. So you can see that fibrinogen treatment not only helps the clot formation, but also the clot dissolution. And then this is another test that shows clot lysis. And this is called a euglobulin clot lysis time. And you have turbidity with the clot until it lyses, and then that cloudiness goes away. And these are patients with very low, very small clots because of low fibrinogen. And they actually do not dissolve fast. They dissolve generally, partially. These are faster and partially at the normal time. This is how we use some global assays to see how our treatment is working. Fibrin monomer is a little piece of the fibrinogen molecule that's cleaved off during clotting, and it's often elevated when you have a lot of clotting in the circulation. And this was the CSL Behring study looking at the half-life of Riostat, their fibrinogen concentrate, and this individual, the normal range is less than 4. And this person had elevated fibrin monomer before the infusion, but after getting fibrinogen, it quickly went up, and then and stayed up for like the full 10 days. So this does show that that it's not the fibrinogen per se, in my belief, that causes excessive clotting in patients with afibrinogenemia treated with fibrinogen, but it's part of the disorder itself that's not 100% corrected by the treatment. But a lot of medicine is paradoxical, which means that two opposite things are done to make things better. And while we can show nicely that fibrinogen treatment increases hypercoagulability, I also use fibrinogen treatment with prophylaxis to prevent clotting, prevent hypercoagulability. So it's a little complicated. So Dr. Acharya talked about some individuals who present later and have very mild symptoms. Well, it's important when you have mild abnormalities in the fibrinogen test to say what could be an external modifier. So it's not a genetic fibrinogen problem, but an acquired one. And we know that you could have increased clot strength if you have inflammation or high levels of your proclotting proteins or low levels of your anticoagulants, or a trait many of you have heard of called factor V Leiden. And you can have decreased clot strength just as a normal finding if you're a newborn baby. You have a decreased clot strength if you have hemophilia or other clotting deficiencies, or if you're on anticoagulant therapy. So if there's a mild presentation, we have to make sure that it's not an acquired problem. Dr. Acharya did talk about how rare afibrinogenemia is, but it turns out to be only 0.5% of all bleeding disorders are fibrinogen defects. And this was from our national US surveillance study, community counts that includes 65,730 unique individuals, and only 0.5% had a fibrinogen defect. Dr. Acharya talked to us about the types and the presentation, and a lot about the laboratory evaluation, and talked about how we confirm it by looking at the antigen. If the antigen's normal, but the function's down, that means you have protein that's not functional. Whereas if the antigen's down and the activity's down, then it means you just don't have the protein. We do family studies to see if it's genetic, and we look at the gene sequencing. And oftentimes we have to make sure that the abnormal fibrinogen was not a byproduct of liver disease, kidney disease, disseminated clotting from like an infection, a disorder called thrombotic microangiopathy, or an immune deficiency. So I'm very, very jealous of Dr. Acharya, who follows some young people who have had very mild problems. And I want to posit that there are many reasons why this can happen. One reason, she showed the areas of the world where it is culturally common and not only acceptable, but promoted to marry cousins. And in those individuals, those families, we have what we call a autosomal recessive homozygous condition. That means that the gene from your mom and the gene from your dad are exactly the same. So when you have a population of people, say from Iran or Turkey, who have a frequent homozygous condition, everybody having the exact same gene will usually have pretty much the same clinical situation, and it can be more severe or more mild depending on that gene mutation. Whereas in the United States, it's interesting. I've been looking at dog breeds, and they talk about, you know, the specific breeding of purebred lines, and they call little mutts casual breeding. So in the US, I think we're all the product of casual breeding because we tend not to be related to each other. And if you have a severe genetic mutation, the mutation of the mom and the mutation of the dad are likely to be two different mutations. And so when you look in a database at all the different abnormalities, it's very likely that that the combination of this unique pair of mutations is going to be a little different than other combinations. So, so that's one reason why some individuals might have more severe disease. Another interesting thing that I think I'd love to talk offline later to Dr. Wilberg about is that in Colorado, we are at higher altitude. So Denver's at 1 mile above sea level, and our mountain communities are at 2 miles above sea level. And that slightly increases the viscosity of your blood. So disorders that are a little hypercoagulable might be more severe up here with the altitude. So I'm going to show you some very difficult stories, but these are the patients that I've dealt with. The first child I ever met with afibrinogenemia presented when he was 2 days old. He was the first baby born to his mom, and he had a circumcision right after birth, and it bled and bled and bled. And his blood count dropped from 22.7 to 19.7, so or 3 grams per deciliter. And they do a little heel stick to do the genetic testing at birth for hypothyroidism and PKU and sickle cell and other traits. And that just kept oozing and oozing and oozing. So he had some clotting studies, and like what Dr. Acharya showed, he had a very long PT and PTT, but a normal platelet count. And I won't go through all this, but he had all of his factors looked at, and pretty much they were all normal for a baby, except for the fibrinogen, which was very low, and the antigen, which ultimately was about 4 milligrams per deciliter. So he had afibrinogenemia with very low levels. So he was treated with cryoprecipitate, and the bleeding resolved, and he was discharged when he was almost 2 weeks old. I saw him during childhood. He came in about every month, and he usually had a muscle, a joint, or a soft tissue bleed, and he would get cryoprecipitate. And there was one period of time when the American Red Cross was making a solvent detergent treated FFP. This was in the era where we were worried about Hep C and HIV in blood, and in individuals who had to get plasma. Although the plasma was tested, because they had to get a lot of units of plasma, the Red Cross tried to destroy any potential virus with a solvent detergent, and he got that. And through his childhood, he always had chronic headaches, always had migraine type headaches. But when he was 15, he started having these lesions that we call vasculitic in his fingers and toes every time he got cryo or the solvent detergent FFP, and it would last for weeks, and it would just be the most boring, burning, searing pain you could imagine. And it actually ended up like necrosing or killing the tips of his fingers and toes. They would turn black like gangrene, dry up and fall off. It was severe pain. He was needing chronic narcotics. And so we were trying to figure this out. And we know that because he had gotten a lot of plasma and cryo, maybe it was an allergy to something in it. Maybe he had an antibody to fibrinogen. Maybe he had immune complexes. So we consulted our local immune experts at the National Jewish Hospital. And we tried steroids. We tried plasmapheresis. We tried various immunosuppressive therapies. And nothing altered it at all. And so this went on for, and you can imagine with such pain. I'll give you one example. He was, when he was 16, his friend had a Rottweiler dog, big muscular dog, who was very happy and pleasant, and ran into him enthusiastically and ran into his quad muscle and caused a big bleed into his quad. And he ended up having to get 64 bags of cryo over a number of days to stop that. And the pain and the vasculitis from that, apparent vasculitis, lasted for weeks and months. So he would only treat for a desperate bleed. It was so painful. So when he was 19, without any treatment at all, he hadn't gotten any cryo or plasma, he had a massive left anterior descending myocardial infarct. And it was so bad, he had to go to a cardiac rehab unit for almost a year to get his strength back. So 19-year-old's massive arterial clot. And then we sent plasma to 2 laboratories, to actually the Stony Brook laboratory, to Dr. Galanakis in Long Island, and also to National Jewish Hospital. And they both looked for antibodies against fibrinogen and immune complexes, and they just could not find any. We even brought him to the centrifuge so we could draw the blood warm and not ever have it cool down and have the best test, but we couldn't find anything. And this is what those lesions look like. He's, you can see his toes would just become black with dark red around them. This is an old healed lesion going up as the dorsum of his foot, and the tips of his toes had necrosed off. He was in agonizing pain. And then a year after the heart attack, he was 20 years old. He developed a headache. He lived with his grandmother, and he told her he had a headache. He was going to go lie down. He went to bed. 20 minutes later, she found him dead in bed. So I felt it was really crucial that we would do a postmortem and try to find out if he died from bleeding or clotting. And indeed, he had a brain hemorrhage. But at the same time, he had changes in his arteries from chronic small clots, that's called bilateral renal arteriosclerosis. And then he had the large heart and LVH from the coronary artery. So he had clots in his coronary arteries, clots in his renal arteries, and bleeding in his brain. So this was kind of like simultaneous bleeding and clotting. I just felt profoundly sad and a failure and befuddled as to what happened. And it seemed that, to me, that constant thrombin generation when he did not have any fibrinogen must have caused these clots. But yet he had such horrible reactions to the only treatment we had in those days that wasn't a very good answer. And he obviously also had a severe bleeding problem. So after he passed away, I met another young child, this one a little girl who was 17 months old, and she presented a little after a year with diffuse bruises and hematomas on her scalp and her trunk. Of course, non-accidental trauma was suspected, and her parents were questioned about this, but a blood evaluation was done, and it revealed that she had afibrinogenemia. She, looking back, had a history that suggested that she had had a muscle bleed at 4 months when she got her immunizations from the needle in her muscle. And she was diagnosed with afibrinogenemia, and she was treated with cryo for every acute bleeding episode. That's what we had back then. And by the time she was 5 years old, she was having recurrent bleeds into her knee. Only about 25% of people with afibrinogenemia get primary joint bleeds, but they do happen. And this child also went on to develop recurrent bleeds into the hip, in addition to oozing with tooth eruptions, and then later on some mild menorrhagia. So this individual also went on to have allergic reactions with cryo, as almost everybody does if you get enough of it for a long enough time, and had to go to the pediatric intensive care unit and get steroids and Benadryl for every single treatment. So at this point, we knew that we needed something better, and the CSL Behring trial for, at that time it was called Hemocompletan, now in the US Riostat, was given. So she was on the trial, well, she was given compassionate use, and actually for a complicated mechanism, her insurance company was able to purchase it from Europe before it was approved in the US because she had such a life-threatening condition. And things went along smoothly. And this individual became an adult, went to university, was just doing very, very well. And one day called the HTC about a sinus infection that just wouldn't clear up with a bad cough. And because of our previous experience, we were very worried about a pulmonary embolus. And we said, go to your local emergency room and tell them that you have afibrinogenemia and we're worried about a pulmonary embolism and to look for that. She had not had any fibrinogen for 5 weeks prior to this symptom. The plasma concentration was at the baseline less than 10 milligrams per deciliter. So unfortunately, hospitals don't know how to deal with rare disorders, and they deal with the wider population. So D-dimer is a test of a fragment that comes from fibrinogen that's elevated as a marker that you might have a PE, and they did that marker and it was undetectable. So they said you're very low risk for PE, not understanding the connection that she couldn't make D-dimer if she didn't have any fibrinogen, and that she could have a PE. So she came to our hospital where she got a CT angiogram and she had 2 PEs. Well, this PE was treated with Lovenox for 6 months, and I'll just admit my failures. We did not know at that time if you needed to be on chronic anticoagulation. So during this 6 months, she was treated with Lovenox and fibrinogen replacement. So when we finished at 6 months, we stopped the fibrinogen to have it go down to the baseline and to try to do these global markers and see if there was evidence of hypercoagulability. But we only made it 8 days and there was already a new PE. So subsequently, we had a terrible 6 months to a couple of years where there were DVTs with or without PEs on Lovenox, on warfarin, on Lovenox with aspirin, and all of these combinations were getting twice weekly fibrinogen replacement. We tried treatment with aspirin and Plavix, but there was a lot of problems with post-thrombotic syndrome. Finally, we had things stabilized on dabigatran, aspirin, and fibrinogen for 3 years. And then, as happens to all of us Americans, a job change and an insurance change mandated a return to warfarin. And lo and behold, 5 years later, this individual presented with severe thromboembolic pulmonary hypertension and had to undergo major surgery to remove that pulmonary artery clot. Again, these things happen when you're in the exploratory phases of a new disorder, where, you know, like for example, where you don't have enough evidence to do everything, but this these changes came on with fibrinogen replacement and with anticoagulation. So this impressed me with how thrombotic some fibrinogen deficiencies can be. So I looked at all the patients that I personally have met and treated, and looking at the most severe bleeding is intracranial bleeding. And with 5 patients with afibrinogenemia, 2 of them had intracranial hemorrhage. Of the 4 carrier parents I've studied, none of them had intracranial hemorrhage. And of 2 patients with hypofibrinogenemia, no one had intracranial hemorrhage. And I want to point out, and then I'll, on the clotting side of VTE, a venous thromboembolism, or a pulmonary embolism, or an arterial clot, or a heart attack, of the 5 with afibrinogenemia, 4 had a thrombotic event. And the one person who didn't was a boy who developed a bone cyst from little microbleeding in his heel. And he started as a child on fibrinogen prophylaxis to try to heal that bone cyst and prevent bleeding. And so he started before, during, and after puberty, always being with some fibrinogen. And, you know, this is way too small a number to say that this is statistically significant, but I feel that fibrinogen prophylaxis, even though you can see studies showing that after treatment, maybe transiently you're a little more hypercoagulable, I believe that prophylaxis to kind of keep you in the low normal range can also prevent these terrible complications. So of 4 individual parents who are obligate carriers of a child with afibrinogenemia, 2 of them have had clots. And then I put here hypodys, and this is something I have to work out. The activity and antigen of these 2 individuals who are a father-daughter are both look like hypo. They don't look dys. The antigen and the activity are very, very similar. But the daughter had a perinatal stroke, and the father had both superficial thrombosis, and he also developed a deep vein thrombosis after surgery. So I think the thrombotic potential of disorders of fibrinogen is high. So these are bleeding symptoms from a European series, well, a worldwide series, but with patients who are A and hypofibrinogenemia. So as I said, joint bleeds in about 25%, muscle in 17, but I just want to point out that intracranial hemorrhage is rated as very low, and thrombosis is rare, and miscarriage is rare. I'm sorry, I think I've gone way over time, but I do want to point out that that miscarriages are universal in afibrinogenemia very early, about 7 weeks. And if you pre-treat with fibrinogen concentrate and you're on prophylaxis and maintain an adequate level, then the embryo can implant, and the pregnancy, you know, can be managed very well. Similarly, patients with dysfibrinogenemia also have a very, very high rate of miscarriage. And we just recently helped a woman who had multiple miscarriages use fibrinogen prophylaxis during her pregnancy, and a month ago she had a healthy baby. So for the women out there, I want to say that there are huge impacts on childbirth and pregnancy, but they can be managed with treatment. So we don't need to talk about any of these. And I just want to conclude that I think there's a very wide heterogeneity in the disorders as well as the clinical severity, and it could be from almost nothing to life-threatening. And I think that thrombosis is under-recognized complication of congenital fibrinogen deficiencies. I want to thank you. Thank you for your attention, and give Dr. Wilberg her time.